Welcome to your lecture over part 6 of your textbook, which is Drugs Affecting the Respiratory System. To start off, we just have a real quick reflection. Your presence is a present to the world. You're unique and one of a kind. Your life can be just what you want it to be. Take the days just one at a time. Don't put limits on yourself. So many dreams are waiting to be realized. Decisions are too important to leave to chance. Reach for your peak, your goal, your prize. Nothing wastes more energy than worrying. The longer one carries a problem, the heavier it gets. Don't take things too seriously. Live a life full of serenity, not a life of regrets. Count your blessings, not your troubles. You'll make it through whatever comes along. Within you are so many answers. Understand, have courage, and be strong, especially where you're young and you're getting ready to start off on your professional life. Just remember of all the potential you have as you're sometimes struggling through various classes or trying to figure out what you wish to do with your life. So we're going to go through two different chapters in this lecture, Chapter 36 and Chapter 37. 36 is going to deal mostly with allergy-type medications. So for this, we're going to talk about antihistamines, which are Benadryl-type medications, decongestants, antitussives, and expectorants. And I'll want you to be able to tell me what the mechanism is, when each category is appropriate to use, when it's not appropriate to use, and of course give examples of all those different types of medications as well. So, just to start, and you may remember this from physiology and you may not, but as far as what histamine exactly is, when you hear the word histamine, I want you to think allergies. Because histamine is an immune-driven thing, and it's very, very particular to dealing with the immune system and the allergic response. So as far as histamine goes, there's two receptors which that chemical in your body works on, and they're so aptly named histamine 1 and histamine 2. Histamine 1 tends to be located mostly through blood vessels in the lungs and in the nose. Histamine 2 is also located on the heart, but then largely in the GI system. The medications which we're talking about today are going to be focused on histamine 1. So what happens when histamine 1 receptors are stimulated by the chemical substance histamine is it causes smooth muscle contraction, which then can result in a little bit of bronchoconstriction. This is why when people have an anaphylactic response, they have difficulty breathing and their airway shuts off. It's from histamine stimulating H1 receptors within the lungs. The other area where they largely live is within the blood vessels, and this is the type of histamine 1 receptors that our medications are going to focus on. While they do work a little bit on the receptors within the lungs, the ones used for allergies tend to produce a better effect within the blood vessels. So what happens when H1 receptors are stimulated within the blood vessels is it causes vasodilation, and as vessels dilate, you just had 2 full weeks over this, but as they dilate, they become leaky and it leads to edema. It also brings warmth and redness. So if you think of a bee sting, how it gets red and warm and itchy, those are all from histamine. You can thank histamine for all that stuff. Where we're focusing in are the blood vessels specifically within the nose. So what happens when the blood vessels within your nose have histamine start reacting with them is they get large and leaky, and as they leak, it causes edema to build up in your nose, which you'll complain of as congestion. You'll feel like pressure and stuffy-nosed. So a lot of our medications are working to cause vasoconstriction of the vessels within your nose. And it's pretty cool that we have drugs which can actually find just those receptors and block mainly the histamine receptors within your nose. Because you can imagine if you had antihistamines that were working throughout the body, that would cause major vasoconstriction, and then you would have blood pressure issues. So for the most part, the drugs we're working on today are going to be working on histamine 1 receptors, mostly within the head, the sinus cavities particular, although if taken at higher dose, they can have effects throughout the body. That's essentially where we're focusing in at today. So as far as the mechanism of action, think of histamine's action and then simply reverse it, because these are just antagonists to histamine, or an antihistamine is probably what you've heard them called as. So histamine's action, essentially vasodilation, and it also helps to increase the secretions, particularly of the nose, the GI tract, eyes will start to water. So histamine, antihistamines will reverse all those too. So you'll end up with dry eyes, dry nose, which is probably what you want if you have runny eyes and a runny nose from allergies. And then histamine naturally increases vessel permeability, and antihistamines are going to work to decrease that permeability. So it broke down to the different areas within the body that H1 receptors reside. And they do reside in more places. I'm just picking out kind of the big ones that we care about today. But from within the nose, what happens when you antagonize histamine 1 receptors or you block those receptors is it decreases the production of secretions. And what this does is alleviates the runny nose people complain about when they have allergies. You know these people because they always carry a wad of Kleenexes with you and they blow their nose like every other minute. So antihistamines help relieve that production of the secretions. Also, it causes vasoconstriction and decreases the vessel permeability of the nose too. And this further helps to reduce the congestion and the runny nose that's associated with allergies. So that's where people a lot of times will say they feel the best. They feel like their nose is unplugged and they feel like they can breathe better. In addition to working on the histamine receptors within the nose, there's also H1 receptors in your eyes. And what happens when these get blocked is it reduces lacrimal secretions. So it helps relieve kind of the runny or the watery eye that sometimes people will associate with allergies. Now, because it is blocking tear production or lacrimal secretions, it's also going to promote a dry eye. So sometimes people will complain of dry eyes after they take these medications. Within the lungs, now it's not going to do a lot down within the lungs because that's not really where these medications are aimed to work. But they do have a little bit of a drying effect in the fact that it reduces bronchial secretions. And it may cause slight bronchodilation, but probably not enough that's going to matter. And for the most part, people who have allergies, their difficulty breathing comes from within the nose. It's not something that resides down in their lungs. Unless they have allergic asthmatic syndrome, in which case then they're actually having a true asthma attack stimulated by allergies. And patients who have that type of disorder are going to be treated by the medications we cover in the next chapter, so they're not probably going to reach for a Benadryl to help get rid of their difficulty breathing. So again, we're focused mostly on the nose, trying to ease the breathing within the nose. And then last but not least on this slide, the H1 receptors on the skin are responsible for stimulating an itch. So this is where, like, if you run through poison ivy, you get hives or you get an itchy rash on your legs. Again, you can, or wherever it is you were brushing up against the poison ivy, you can thank histamine for that reaction. So when you block histamine, it kind of blocks that itch, which is why we have over-the-counter topical Benadryl and hydrocortisone and all those anti-itch creams a lot of times could also be thought of in this context. So how exactly it does this is it prevents the release of histamine from basophils and mast cells, which are both components of your immune system. By blocking the release of histamine, it can help prevent allergies. So somebody who might use an antihistamine in this aspect might know, like for example, I have a friend who's allergic to peanut oil. So whenever we go to Huhat, she'll take a Benadryl before going there because she knows there's a risk that she might be exposed to peanut oil. Now her allergy is very minor, so it doesn't cause really an anaphylactic shock. It causes more like itching. So just taking a Benadryl will help protect her. Another instance when somebody might take it to prevent the release of histamine from the immune cells is if they're going to a friend's house and that friend has a cat, or if they're about to mow the yard and they know they get seasonal allergies from grass. They know they're going to encounter an allergy and they wish to prevent it. So then you might take it before the allergies start, and that's how the medication's working in that aspect. The other time when an antihistamine is used is when the allergy symptoms have already arose and the patient is already miserable from allergies. So now we actually want to take it to reverse the symptoms of histamine. And this is where antihistamines are going to be a little bit different than, say, your corticosteroids. A lot of the medications we cover today, and I'll be deliberate in telling you these prevent allergies or these treat allergies. And your antihistamines, this group of medications, is good at both preventing and treating allergy symptoms. There will be a lot of groups we talk about which are only for the prevention, so if you wait until you have allergies to take them, it's not going to help. it's going to be irrelevant. So the other way that antihistamines can help treat allergies, so you wake up and you've got stuffy nose and a watery eyes and your allergies are full-born. The cat slept on your head or something happened and you have allergies. You can take an antihistamine to block the effect of the circulating histamine that's already been released from the immune system. And this is going to help stop current allergy symptoms and help relieve some of those symptoms too, which is how antihistamines are a little bit different from some of the other groups we're going to talk about. Now, antihistamines are divided into two different types. There's first generation, second generation. To make things a little bit more complicated, first generation can also be called a typical antihistamine or a sedating histamine. And then second generation antihistamines can also be called atypical or a non-sedating antihistamine. All three of those names are referring to the same group of medication. I typically will call them either a first generation or a second generation, so that's how you'll see them appear throughout your notes for the rest of the day. But know if you hear a typical antihistamine, that person's referring to a first generation, or if you hear them call them a sedating antihistamine, again, it's first generation. As a rule of thumb, your first generation is always going to be your oldest generation, so you can think of your first generation being your old antihistamines as well. While they're very good at what they do, they cause a lot of side effects, whereas your second generation were introduced in like the 1990s, I think, and they have fewer side effects associated with them, so they tend to be a little bit more user-friendly. So when to use and when not to use. As far as indications for antihistamines goes, they're very broad, and there's a lot of different things you probably didn't think about using an antihistamine for. Just starting at the top of your list there, obviously nasal allergies. And if you're taking them for the relief of allergies or to prevent an allergy, you can take either first generation, which would be the Benadryl, or you can take a second generation, which would be a Claritin type medication, or Allegra or Zyrtec. Any of those would be second generation. Same thing with seasonal or perennial allergies. Seasonal would be something that, actually they're both something that like you come in contact with, so hay fever. Every spring you end up with allergies, or every fall you end up with allergies, or whatever it might be. For seasonal or perennial allergies, again, Claritin or Benadryl, so first or second generation antihistamines are appropriate for use there. Now where we start getting into areas that's not so much anything goes, allergic reactions are typically treated with Benadryl. The reason being is it tends to be a little bit more effective at stopping that circulating histamine that's already moving around the body. Plus, we can give Benadryl IV. So if somebody comes to the hospital and they've got a massive hives, or I see this not all the time, but frequently on the surgical unit. Patients will have a reaction to something within the anesthesia and they come up and they've just got a red rash on their body. We'll give them a dose of IV Benadryl to help stop all that circulating antihistamine and take care of the itch. So therefore, Benadryl's a little bit more better for current allergic reactions. The next thing that you may or may not think about an antihistamine being good for is motion sickness. And you've probably heard of using Dramamine for motion sickness, but what I bet you may or may not have known is that Dramamine is also a first generation antihistamine. So like Benadryl and Dramamine are both part of the same group of medications. They're like brother, sister, brother, brother to each other. They're very similar. So you can take Dramamine for motion sickness. You can also take Dramamine for nausea if you have an upset stomach, and that tends to work really well, especially in children. And the reason why you can use Dramamine for motion sickness is because it's also Dramamine's good at working on H1 receptors, but it also blocks H2 receptors, which are located within the GI tract. So kind of a little bit of an off-label use for it. Another thing that you may or may not remember can be used is Parkinson's disease. Because Parkinson's is a disease of out-of-control acetylcholine, you can take an anticholinergic medication, which Benadryl happens to be, to help tap down the activity of acetylcholine. So every once in a while we'll see Parkinson's patients who come in because, and they're on Benadryl for that reason. And then the other thing that's pretty common for people to use is Benadryl for the treatment of insomnia, particularly if it's insomnia like I have to work tonight an overnight shift, so I want to sleep during the day, I'll take a Benadryl in the morning, and then that way I kind of sleep through the day so I have some rest to go tackle my night shift. Another time it might be used is for people who have jet lag, and they need to get a little bit extra sleep as well. As far as when not to use, patients diagnosed with narrow angle glaucoma should not use an antihistamine because it does increase intraocular pressure as it decreases lacrimation. Little fact for you. Also, people who have impaired liver or kidney function need to use antihistamines with caution. It's probably these drugs aren't going to induce renal or liver failure in a healthy person, but people who have misfunctioning organs, these drugs just build up a little bit quicker and they're not always useful for those patients. And then with pregnancy and lactation, this gets kind of tricky, and we're not going to spend a ton of time on it, but some are okay and some aren't. Like Benadryl is okay during pregnancy, but I think its Dramamine isn't. So just if you or somebody you know happens to be pregnant and you're having allergies, make sure you check with the drug book to make sure that whatever it is you want to take is okay to take, or you could encourage patients to call their physician to make sure that that's okay before they take it. And the same thing with lactation. Some are okay and some aren't. So just always check with people who are pregnant to make sure it's safe for them to take. So some of the adverse effects of antihistamines. I've got this divvied out into different systems in the body. The first one being cardiovascular, and this is largely caused by blocking acetylcholine, so the anticholinergic effects. Can cause a little bit of a hypotension and dizziness, and can also cause palpitations. The central nervous system, if it has a little asterisk behind it there, a little star, that means it's more specific to the first generation medication. So like the sedation is more common with Benadryl than it would be with Claritin. Same thing with respiratory depression, more common with Benadryl than Claritin. And the respiratory depression is going to be more likely to occur if the patient is taking another type of depressant medication. And by depressant, I don't mean antidepressant, I mean like alcohol or a benzodiazepine or something that depresses the central nervous system. Another example would be an opiate pain medication. The next one on your outline is paradoxical excitement. And this, if you ever know somebody who says they take Benadryl and it does nothing to make them sleep, this is what they're experiencing, is the paradoxical excitement. And it's just an idiosyncratic reaction. Typically it causes sedation, but in some people it actually causes them to be more alert. So it's kind of one of those weird things that some people just react differently to it. For the GI, because it is decreasing or has the potential to decrease secretions, it can cause a little bit of nausea and vomiting as it slows down the GI tract. Now, keep in mind the GI adverse effects are going to be a lot more common at higher doses than they are at lower doses. So if somebody's just taking the recommended dose, they're probably not going to get a lot of GI upset. But if they're taking a double dose for some reason, then they might notice that. A few just other miscellaneous things, and they're caused by the anticholinergic effect of these medications. So they're going to be more prominent with the first generation. Then the second is going to be the dryness. So a dry mouth, dry nose, and a dry throat. Everything just kind of dries up with your anticholinergic because you're blocking the rest and digest, so you block a lot of the lubricating things of the body. And the other thing that can happen is urinary retention. And again, it's more common with the older or the first generation antihistamines than the second generation. It's not to say that if somebody wasn't taking a high dose of a second generation that couldn't cause it, it's just less likely. Let's see, and then same thing with the dry eye there. And again, the little asterisk just means it's more common with the first generation rather than the second. Some of the interactions, alcohol is going to increase the sedation component, mostly of the first generation, as does it increase the risk of respiratory depression. So it just makes the patient a little bit more sleepier, and it kind of depresses the CNS system a little bit more. MAOIs is a type of antidepressant that we covered way back in the beginning of the class. And this type of antidepressant is the one that if people eat food that has tyramine in it, it can cause a hypertensive crisis. Same thing if somebody takes an MAOI with a histamine, antihistamine medication, it can also cause a hypertensive crisis. And then CNS depressants, including benzodiazepines, opiate pain medications, they also just increase the risk of sedation and respiratory depression. So we typically tell patients to avoid taking both at the same time, or if they do happen to take both at the same time, know that this is going to be a risk factor, or this is something that's probably going to happen. Going back to my example of giving patients after surgery IV Benadryl for a reaction, those patients almost always take a really good nap because they have all their opioids on board for pain control for their surgery, but then I've also given them IV Benadryl. And your IV form is always going to be more potent than your oral form, so I've really given them a good sleep aid for a couple hours. As long as you're monitoring it, it's not going to be a big deal health-wise. It's just something you want to be aware of and kind of monitoring the respiratory rate a little bit more carefully than you maybe would have. My other cautionary note is patients who have BPH, which is benign prostate hyperplasia, typically happens with men in their middle age. If they're taking a first-generation antihistamine, they're going to be the ones who are most prone to that urinary retention. For the most part, that side effect doesn't really affect anybody else besides that specific group of people. So you might just want to make a little note there that that's kind of one of the weird things with the first-generation antihistamines. So the drugs to know. There's many that could be covered here, but I've just selected some of the two most common ones. The first one is loratadine or Claritin. You might have heard the slogan Claritin Clear. This is a second-generation antihistamine. Because it's second generation, it could also be called a non-sedating antihistamine. Hence its slogan Claritin Clear. You're clear, you're not drowsy, non-drowsy. Second generation, so it's going to have a lot fewer side effects, particularly fewer anticholinergic side effects. And remember, your anticholinergic were going to be the dry effects, so the dry mouth, dry nose, dry everything. It still might produce a little bit of that, it's just not going to be to the extent that the first generation would. And then the other side effect that it does much less of is sedation, which is why most people will take a Claritin over a Benadryl. Because if you're getting up for the day and you wake up and you have allergies, you probably don't want to take something that's going to put you right back to sleep if you need to go be productive that day. So for that reason, sometimes people would rather take Claritin so they don't sleep all day. And the reason why the second generation has fewer side effects, it's not because it's newer, it's because we were smarter in developing them, which also happens to be newer, but these only act peripherally, whereas the first generation act both peripherally and centrally. So if you can remember, the second generation are acting more peripherally, they're not going to have the central nervous system side effects that the first generation would, as a rule of thumb. The other big benefit to these is they've got a long duration of action, so there's only once daily dosing, whereas Benadryl, you'll end up taking that about 3 times a day if you're taking that for allergy relief. So once a day dosing is a little bit more convenient for patients, and typically they take it in the morning when they get up, and then the drug's doing most its good during the day, and then as they fall asleep, it doesn't stimulate them to stay awake all night either. This medication used to be prescription only, but in the last, I think, 5 years or so, maybe closer to 10 years, I don't really know, it's become over-the-counter. So this is actually an over-the-counter medication as well. And this is one that is only indicated for the treatment of allergies. It really doesn't do much anything else. Like Benadryl, you can take that for just about anything. Claritin is really just allergies. That's all it's good for, but it is really good at controlling allergies. And then a few other second generation medications, not that you need to frantically be writing these down, but just you might have heard of them because they get advertised a ton. Allegra-D or Zyrtec is another one that you might hear. And they're all cousins to Claritin. They all act very similar to each other. The first generation antihistamine, I was going to say the second medication you need to know, and then I thought that might get kind of confusing. But the other drug you need to know is going to be Benadryl. I would wager that you've probably heard of this at some point in your life because we like to use it for just about everything. This is a first generation, or you could call it a traditional, or you could call it a typical, or you could call it a drowsy or a sedating antihistamine. It's got all those names associated with it. And this one is going to work both peripherally and centrally. Because it's working centrally, it's crossing the blood-brain barrier. It's very lipophilic is what they call it, which means it's kind of a fatty medication that it crosses those fatty barriers really easily. So therefore it crosses the blood-brain barrier really easily, and that's why it gets kind of the drowsiness, respiratory depression, some of those side effects associated with it, whereas the Claritin didn't have that. One or two big benefits to Benadryl is it's over-the-counter and relatively safe, particularly for children, plus it's very inexpensive. So it's a good medication for you to just kind of have around the house for whatever. We do tell people to use it cautiously in the elderly population, and the reason why we say that is the elderly population tend to be, I hate to say this, but they tend to be a little bit dried out anyways, just because their body just doesn't function like it once did. So then if you start giving them a lot of anticholinergic type medications, it can cause them to have severe dry mouth, severe dry eye, severe constipation, some really severe anticholinergic effects. So you want to be careful giving anything that produces anticholinergic effects to people, generally over the age of 65, just because you don't want to cause too many uncomfortable side effects for them. So that's why we use it cautiously in the elderly population. As far as routes, you can take this about any way you choose. It comes in capsules, tablets, syrups. You can give it intravenously within the hospital. And then there's also a topical cream for like rashes, bug bites, contact dermatitis, stuff of that nature. For the indications, allergies is the big thing, and it can either prevent or treat existing allergies. So you can either take it before you're coming in contact with the allergen, or if you come in contact and need to be rescued from your allergies, Benadryl will do that as well, as will Claritin. Benadryl can also be used to treat insomnia, and it works best for short-term insomnia. Benadryl is a medication that if you take it every day for like insomnia or anything, pretty soon it's not going to work as well as it once did. It tends to decrease its effectiveness over time. Same thing with the second generation antihistamines. People will a lot of times say, man, this worked really good at the beginning of allergy season. So if they have like springtime allergies, they might say it works really good during the months of March and April, but by the end of May, I notice it doesn't work as well anymore. And that's just because your body builds a little bit of a tolerance to these drugs. Same thing with Benadryl. If you take it nightly for insomnia, pretty soon it's not going to work anymore, and you'll need to give yourself a little bit of a drug holiday from it. It can also be used to treat Parkinson's disease because it's anticholinergic, and then motion sickness as well. And the drug that's the best if you're going to use it for motion sickness, because it works really well on H2 receptors as well, is going to be your Dramamine. But you could try Benadryl. You'd want to take a high dose of Benadryl, so you'll probably sleep for your entire flight or drive, but you could try Benadryl as well. Some of the other first generation medications that you might have heard of include Dramamine. Chlortriptotine, that is one that's really popular in the pediatric population, I guess. I don't see many adults use it, but I know like that's what mom swears up and down you have to use on kids. So it's not that you have to, that just tends to be where you see it used more frequently. And then the next one we'll actually cover when we cover GI medications. It's Phenergan or promethazine, and that's an anti-nausea medication that again is working on both H1 and H2 receptors. So it has a little bit wider ability to treat a couple more diseases or disorders. Moving on to the next category of medications, we have our decongestants. So to understand how these work, first you have to kind of understand, well, what causes congestion? And some of you might already know this from other courses and some may not. So as far as causing congestion, it's typically caused by excessive nasal secretions and an inflamed nasal mucosa, and that can be caused by allergies, can certainly do it. Otherwise, upper respiratory infections would be the other big culprit of causing congestion. So how we treat it, we have three main options. The most common one by far is going to be to grab an adrenergic agonist. Adrenergic agonists work by constricting the nasal arterioles via stimulating the sympathetic nervous system. So if you think of stimulating the sympathetic nervous system, it kind of causes a vasoconstriction throughout the body to amp up your body. So now we're using it, and these medications are designed to specifically focus on the arterioles within the nose, so it doesn't cause a real bad systemic flare-up of the sympathetic nervous system. It's more confined to just the head. But it does constrict those nasal arterioles, which enhances the draining of secretions. It also helps reduce the feeling of pressure because there's less blood and less of the immune system kind of flowing through the nose. And then it also helps decrease the congestion patients will complain about. So those are your adrenergic agonists. They stimulate the sympathetic nervous system, shut blood away, kind of get the immune system out of your nose, and it helps relieve the edema. The next group that you could use would be an anticholinergic agent. So if your adrenergic agonists just stimulate, all your anticholinergic agents do is inhibit the parasympathetic nervous system, which then allows the sympathetic nervous system to step in and take over. They don't work quite as well for nasal congestion, but if you had somebody that was maybe allergic to an adrenergic agonist or for some reason didn't want to take it, they could certainly try an anticholinergic agent. But if somebody could take an adrenergic agonist, that would be more ideal than your anticholinergic, just because the anticholinergics don't work quite as well. The third group we have are the corticosteroids, and we've talked about these back in, I think it was chapter 33 when we talked about hormone stuff. These are the same types of corticosteroids, but typically when used for congestion, for nasal congestion, it's just taken intranasally. So it's inhibiting the inflammatory response, but only within the nose, if that makes sense. By inhibiting the inflammatory response, it reduces the allergic reaction. But the kicker here is it's good at reducing allergic reactions and it's good at relieving congestion if you take it before the allergy is exposed to the patient or before the patient's exposed to the allergen. Corticosteroids, whenever you hear that, think one, immunosuppression, because that's what they're good at, but then two, think that they take a long time to kick in, because they do. We'll talk about them now with allergies, and we'll talk about them again with asthma. And both things, they're really good at preventing allergies, but they're not very good at stopping them once they start. The nice thing about, or the other note about taking corticosteroids intranasally, is it's only working within the nose. And if they're taken appropriately, so for example, if the patient's not overusing them, they shouldn't go anywhere besides the nose. For that reason, they're probably not going to cause a lot of systemic side effects. The other thing you probably remember from corticosteroids earlier in the semester or in the class is that they have side effects that are like a mile long. Your intranasal aren't going to have that. The side effects are again going to be largely located only within the nose, and they're going to be pretty minimal unless the patient's, like I said, overdosing to where they have it running down their throat and they're swallowing it and they're just totally ODing on it. Otherwise, they should be pretty safe. So routes to select from when you're taking a decongestant. There's oral and there's topical. And the topical route would be an intranasal. So if you think of rubbing something up your nose, or you can just rinse it up your nose. As far as what divides them apart, the oral, because it's absorbed from the stomach and goes around the body systemically, there's going to be more side effects associated with it. The other drawback to the oral route is it's going to have a longer onset of action. The intranasal kick in really, really fast, whereas the oral, of course, have to be broke down by the stomach and then absorbed, and then they have to find their way to your nose, so it just takes a little bit longer. They also tend to be a little bit less potent than the intranasal medications. So after thinking about those three reasons, you're probably like, well, why would anybody take an oral one? And the reason being is the topical, although they're a lot faster to kick in and they have fewer side effects and they're more potent, the drawback to the topical or the intranasal is that it causes what we call rebound congestion. And I'm going to jump to that rebound congestion right now for just a second. And what this is it's simply referring to worse congestion once the medication wears off. So if you think about it kind of as your body gets a little bit tolerant to this medication to where it needs it to function, so you're taking it on a daily basis, your body gets used to having it in its system, and then suddenly you take it away. It kind of confuses your body, and your vessels react by becoming really dilated. It's kind of the opposite of what happens with caffeine, or actually it's the same thing that happens with caffeine, whereas if you take it on a daily basis, your vessels get used to it. And then if you suddenly stop drinking caffeine, you get a horrible headache. Well, if you think about this, taking it and your body gets used to it and then you stop it, you're going to have really bad nasal congestion. So it's going to feel like you have a wicked head cold. What this typically, if you don't tell patients that this can happen, what happens is they take it and they feel better, and then the next day they feel kind of stuffy, so they take their medication again, and they do this over a period of about a week. It only takes 3 days for this rebound congestion to build up. So after about 3 days, they're like, oh, or 3 to 5 days, they're like, oh, why don't I feel better? I feel better when I take my medication, but then I feel worse once it wears off. This is what's happening, and at that point, they just have to quit it cold turkey to reverse it. So that's the big drawback to your intranasal decongestants, that they're really good for short-term use, but you really don't want to be on them longer than 3 to 5 days, because then you're going to have this terrible syndrome where it just feels like you have a worse cold than you started with when you get off them. And that's only going to be associated with the adrenergic agonists. The other two categories actually don't cause that. Your adrenergic agents are going to be good at relieving existing allergy symptoms, whereas your other two, the corticosteroids and the anticholinergic agents, are not going to be. So the benefit to the corticosteroids and anticholinergic drugs is they don't cause rebound congestion, but if you wait to start taking them once you feel your allergies, so your allergies have already set in and you already have a runny nose and you already have congestion and you can't breathe, and then you start taking a corticosteroid, it's not going to work. It must be taken before the onset of allergies so that it can prevent the onset. So that's kind of the drawback to corticosteroids, is you have to know when that congestion is going to set in, and most people don't know when exactly it's going to happen, so that's one of the things that's a little bit less user-friendly with the corticosteroids and the anticholinergic agents. So a little bit more on the decongestions as far as the do's and the don'ts. The do's are when you can use this for acute or chronic rhinitis, which is just a runny nose. And for this, you're going to use the intranasal form to help stop that. Again, if you're using an adrenergic agonist, which you most likely are because it's the best one, don't use it any longer than 3 days or you're going to feel like you have a head cold from HE double hockey sticks. Might also use it for relief of nasal congestion with the common cold, and for this one you could use either intranasal or oral. If a patient's taking it to relieve a runny nose from the common cold, it's almost better to take the tablet form of a decongestant because it's not going to cause that rebound congestion. And typically colds last longer than 3 days. If you've ever had a cold, you can probably attest to that fact. The next indication would be sinusitis, which is just inflamed sinuses. And this is another one that depends what the cause of it is. If it's a viral infection, or if it's from an infection, the tablet form would probably be better than the intranasal just because you can take it longer without that rebound occurring. And then next would be hay fever. Hay fever is one where the oral would be way better because people who complain of hay fever typically complain about it all summer long, or as long as that cut grass is circulating in the air. So you have to think about, well, how long are they going to be on this, and should they be on oral, should they take an intranasal? What would be better for the patients there? Some of the do nots use this, and I didn't really know how to abbreviate don'ts. I felt like I should have another apostrophe between the T and the S, so don't critique my grammar on this slide because I'm not entirely sure if that's even a word. Anyway, as far as when these medications are contraindicated, patients with narrow angle glaucoma, again, it can increase the pressure in their eye and cause vision damage. And then and I'm talking mostly about the adrenergic agonist right now, because it's stimulating the sympathetic nervous system, it can be really hard on people who have uncontrolled cardiovascular disease, particularly hypertension. If somebody has just like controlled hypertension, or if they don't have hypertension at all, it's probably not going to affect them that much. But if they have uncontrolled cardiac disorders, then it can become a problem for them. Same thing with the diabetic patients. We use it cautiously in them, more so with the tablet form of a decongestant than the intranasal. But it can stimulate the sympathetic nervous system is what it does, and by doing that it can cause the liver to release glucose, stored glucose, which then can cause their blood sugars to spike. So we use it cautiously again in patients who are diabetic, not that they can't use it, just need to keep an eye on their blood sugar. And then patients with severe hypertension that's not very well controlled might want to be a little bit aware of using this or use these medications with caution. Some of the adverse effects, so the tablet form or the oral adrenergic agonists, are going to cause essentially stimulation of the sympathetic nervous system, and you're going to see some nervousness, potentially some insomnia, palpitations, tachycardia, tremors, kind of those amped up responses from stimulating the sympathetic nervous system. As a little side note for you, sometimes they will combine an oral adrenergic agonist or agent with Benadryl to help counteract the drowsiness associated with the first generation antihistamine drugs. So it's not unusual to see these combined to help cancel out each other's side effects. And again, patients will probably complain of, feeling a little bit nervous, have a little bit of a tremor, tachycardia, and that's all pretty benign. We know it's going to happen. It's not terribly scary. It's just something to let them know about. With the intranasal decongestants, all three groups are really well tolerated. They might dry out the nose, which is kind of what they're supposed to do, but with that dry nose, is it can also cause patients to have nosebleeds a little bit easier than they would otherwise. So just let them know, you might have nosebleeds. Don't be alarmed. Teach them how to take care of a nosebleed, and that'll be fine. And then just to remind you, if they're taking adrenergic agonist, they need to be aware that if they take it long-term, the intranasal form, it's going to cause that rebound congestion, which is going to feel like a wicked head cold and won't be much fun to go through. So the drugs to know, the first one is Sudafed, which is your adrenergic agonist, which is known to cause that rebound congestion. So your Sudafed is a great medication to use as a decongestant. You can get it either in the oral route or the intranasal route. I believe this is the medication that's actually used in the production of meth, though, so it's a little bit more difficult to get than some of the other medications. But the reason why I included that, or why I went off on that little tangent, is if you can remember, that's used in the production of meth. Kind of remember what meth does to the body if you think about, or if you know what meth does to the body and how hard it is on the cardiac system. Kind of combine Sudafed and the cardiac system of having to use that carefully, because it could have, not to the degree meth would have, but it could have some of those same side effects, particularly the tachycardia, and then it could cause hypertension. So just as a trivia for you, I guess. Other side effects of this can include nasal dryness and then a little bit of nasal burning. Nothing to be concerned about, but just let your patient know that when you take this medication, the nasal form, you might notice your nose dries out a little bit. And that's Sudafed again. So for your anticholinergic medications, again, it's not used. This group of medications isn't used very frequently for nasal congestion, but they could be if somebody, say, they did have uncontrolled hypertension, they did need something to control their nasal congestion, then maybe an anticholinergic agent would be suitable for them. The only one on the market approved for this indication is Atrovent, and we're actually going to talk about this when we talk about asthmatic medications. So there's more to come. Again, just know it's not used very frequently, but it's blocking the parasympathetic nervous system, which then allows the sympathetic nervous system to dominate the body, and then it acts kind of like a weak Sudafed at that point. And then the last group of medications to know are the intranasal corticosteroids. And these are two that if you walk down the pharmacy aisle at Walmart, you'll see these, because I think they're both over the counter now. And they're both very common. But this is going to be Flonase and Nasonex. And I forget which one of these, if you watch TV, one of these has got the French bee that flies around pollinating flowers and telling people about allergies. If you watch commercials, you'll see him pop up again. I think it's Nasonex, the Nasonex B. And just as a friendly little ID tool, they'll almost always have that SONE somewhere in the generic name. So if you see SONE, and again, that goes for any corticosteroid. Not that that's a hard and fast rule, but that's an easy way if you don't know a drug and you see that SONE in there. If you had to make a bet, I would bet it's a corticosteroid. So anyway, moving on though, Flonase and Nasonex. As far as what they can be used, they can decrease the congestion in the nose, but the big drawback to these medications and why they're not first line is they take about 1 to 3 weeks before you see any sort of an effect. So therefore, they're very good at preventing if you have 3 weeks to prepare for allergy season. If it's something where you wake up with severe nasal congestion, this medication isn't going to help you a whole lot though. The other thing with corticosteroids or with the intranasal form is the effectiveness is going to decrease with usage. So again, people say, yeah, they worked great at the beginning of allergy season, but by the end they were kind of so-so. And then the following year, if they don't take them all winter and then start up again in the spring, they'll say, yeah, it works really well. And then midway through allergy season, they'll say, yeah, it's okay, but it's not great. And it's just the way your body interacts with them. They do decrease a little bit with time. For these corticosteroids, when they're taken by the intranasal route only, and they're taken appropriately, so somebody's not, squirting half the bottle up their nose at a time, there really should be very few systemic side effects. The only side effects that they should note is maybe some nasal irritation, maybe some sore throat, maybe some dryness, but nothing that's real significant. However, if you swallow these medications, if you take the bottle and would swallow it for some reason, or if you have a child in the house who decides to drink it, then it can have systemic side effects. So for that reason, it's important for safety to keep these up out of the reach of children. And also, if a patient's taking it and they take too much and some dribbles down into their mouth, spit it out, don't swallow it so you don't get the systemic side effects associated with this drug. The next group of medications we have to talk about are the antitussives, and these are great medications for suppressing a cough. In fact, that's what antitussive is. Tussive is to cough, anti is to stop, so you're stopping a cough. These can work in a couple different ways, but essentially, however they work, they're going to suppress the cough reflex. They may do this either by raising the cough threshold, or they may anesthetize or numb the stretch receptors in the lungs. Either way, it's going to suppress the cough though. For these, the appropriate cough to use this for is if the cough is dry, so they're not coughing anything up, or it's unproductive. Again, they're not coughing anything up. If they're coughing up phlegm, they should not take an antitussive because you don't want to suppress a productive cough. And the reason why you don't want to suppress a productive cough is what happens if somebody's got a productive cough, they're coughing up lots of mucus, you give them their antitussive and they stop, that mucus doesn't disappear. It just stays sitting in the lungs, and the mucus, if you were to put it in a petri dish and let it grows all sorts of fun, disgusting bacteria. So if you think of all that bacteria just sitting down in the lungs, which is a nice, clean, sterile environment, it leads to pneumonia really, really fast. So therefore, if they're coughing up mucus, that mucus must come out, so therefore they need to cough it out. Bottom line, don't give a patient with a productive cough an antitussive because I'll get really upset at you. And so will your patient when they have pneumonia. There's two types of antitussive agents. There's opiates and there's non-opiates. Opiates are going to be a little bit stronger and they're going to work a little bit more centrally within the respiratory drive in the brain. And how they do this is they directly suppress the cough reflex by suppressing the cough threshold within the central nervous system, within the medullary center in the brain. In addition to suppressing the cough reflex, they also provide a little bit of a pain relief. So if somebody's been coughing and they've got a sore back or a sore stomach or a sore throat from coughing, it'll help ease some of that pain as well. It's a really low dose we use when we're using an opiate type antitussive agent as compared to an opiate for pain relief. So it's not a potent pain relief, but it does take the edge off a little bit, which is good. The other thing that the opiate antitussives do is they dry out the body, just like your pain medications did. So they produce a drying effect on the respiratory secretions as well. So then it can help suppress the mucus from ever being created, so it doesn't, your non-productive cough doesn't turn into a productive cough as well. And then the other type you have is the non-opiate. So the non-opiate is going to be your over-the-counter antitussives that if you develop a cough, you can just run to the grocery store and pick it up. Your opiates, you'll need a pain medic or a prescription for though. But your non-opiates are going to work by either suppressing the cough threshold peripherally or by anesthetizing the stretch receptors. The drawback to the non-opiates, the benefit is they're over the counter and you can just go grab them, but the drawback is that there's no pain relief or drying mechanism associated with them. So that's kind of the drawback to the non-opiate type antitussives. So the indications, again, a non-productive cough. In fact, for your contraindications, the first thing I listed there was a productive cough because you don't want to cause pneumonia on your patients. That would not be a helpful thing for you to do at all. The only other really contraindication to your antitussives would be if somebody was allergic to them, or for the opiates, like you obviously want to give a patient who was comatose and probably an opiate or any other antitussive agent. So they're relatively safe. As far as the adverse effects, I think I have just a note in your outline that we'll go through them with each drug profile. So we're just going to step right into the three different ones you need to know. The first one is the Tessalon. Tessalon is a non-opiate antitussive agent, and how this works is it's going to anesthetize or numb the stretch receptors within the lungs. Now this medication is nice in the fact that it works within about 15 to 20 minutes, but it also wears off fairly quickly. For that reason, patients will end up taking this fairly frequently through the day to help suppress their cough. It is an over-the-counter medication. Some of the side effects include a little bit of dizziness, headache, maybe some sedation, maybe some nasal congestion. And then the other thing that's kind of unique to this, because it's anesthetizing the stretch receptors, if somebody, and it's typically children who do this, if they decide to chew on this medication and then swallow it versus just swallowing it whole, it'll cause their whole mouth to go numb. If a patient doesn't know that's going to happen, sometimes it freaks them out, so you might want to let them know. Make sure you swallow this whole, because if you don't, that medication gets released in the mouth and then it doesn't work quite as effectively for being an antitussive agent. It would work really well if you're trying to numb your mouth, but if you're trying to take it to suppress a cough, you need to swallow it whole and not be chewing it up in your mouth. The next one, which is probably a little bit more commonly used than even the Tessalon, would be your codeine. And you've probably heard of people saying, oh, I took cough syrup with codeine. Well, essentially, they just took codeine in a syrup formation. This is going to be the opiate type antitussive agent, and it's a Schedule 5 when it's used as a cough suppressant. If it's used for pain, though, I believe it becomes either a Schedule 2 or 3. The reason why it's a Schedule 5, why it's such a low schedule for an antitussive agent, is because it's such a small dose that's administered in this that a patient would have to buy out the entire pharmacy if they were just taking cough syrup with codeine in order to get a high. So therefore, people who are addicted or trying to seek this out for that reason typically won't go for cough syrup with codeine in it, just because they'd have to get so much of it to cause any sort of an effect. So for this reason, it can be a Schedule 5 when it's used in this aspect. It is prescription only, so you have to go to the doctor and get a prescription for it. And it's contraindicated in patients who have severe respiratory disorders or people who have seizure disorders, because it does lower the seizure threshold slightly. Some of the side effects are going to be typical of your opiate medications, and those include sedation, nausea, vomiting, constipation. We do tell patients to take this with food to help prevent the nausea and vomiting and whatnot. And we tell patients not to drive any heavy equipment or operate heavy machinery while they're on this medication, because it does affect the reflexes a little bit. Not as much as it would if they were taking codeine for pain relief, because that's a higher dose, but you still want to be careful with it. The last antitussive you need to know is Robitussin, or dextromethorphan, I think is how you say it, but Robitussin. And Robitussin is another non-opiate antitussive agent, and we're kind of moving in order of least used to most used. So Tessalon is going to be your least used because it's kind of a retarded antitussive. It works okay, but not great. Codeine is probably going to be the second most used, and then Robitussin is going to be the most commonly used here. And how this works is it raises the cough threshold, so it works a little bit better than the Tessalon does, and it lasts a little bit longer as well. It is over-the-counter, non-habit forming, and relatively safe, although with any medication you certainly don't want to overdo it because you could, if you took enough of it, you could cause damage, but it's relatively safe. Some of the side effects of Robitussin include dizziness, drowsiness, and some nausea. If they take this with food, the nausea should be decreased. So if it's somebody that has a sensitive stomach, I'll just tell them to take it like with a piece of toast or something. And then the last group of medications we have are the expectorants. What an expectorant does is it makes it easier to cough secretions up. So going back to our patient who has a productive cough, you're not going to give them Robitussin or codeine or Tessalon because that's going to keep the mucus within their lungs. What you're going to give that patient with a productive cough is going to be Mucinex because Mucinex is going to help break up that mucus and get it out of their lungs so it doesn't cause pneumonia. And how it does this is it makes the cough secretions easier to cough up, and it does this by reducing the thickness or the viscosity of those bronchial secretions. So essentially just thins them out so that's easier, they're less sticky, and it's easier to get them up and out of the lungs. It can do this either by a reflex stimulation or a direct stimulation of the secretory glands within the respiratory tract. And again, this is going to be used for patients who have a productive cough. You probably won't give this to a non-productive cough because it's not going to do anything to them besides keep them coughing. The only drug you need to know here is Mucinex, and you might have seen the little mucus commercial. It's a little mucus guide that their slogan is Mucinex in, mucus out, and it's a little green blob that he's always having parties in people's lungs. It's kind of rude of him, but he does it anyways. And some of the adverse effects of Mucinex include nausea, vomiting, gastric irritation. Nothing real significant there, so as long as they're not allergic to the medication, it's typically okay that they take it. Just another friendly tip, if somebody has a productive cough, you also want to encourage fluids, particularly warm fluids, because that also helps the patient cough up secretions. So you give them their Mucinex and you give them a full glass of water or a cup of coffee, and they should be good to go for a little while. And that ends chapter 36, our anti-everything, antihistamine, decongestion, antitussives, and expectorant chapter. And now we're on to chapter 37, which is going to be the true respiratory think of your lungs drugs. For your objectives here, we're going to, I erased the first one, which was discuss the anatomy and physiology of the lungs, because I think you've probably all gotten that from A&P. So what we're going to do today is discuss the impact of respiratory drugs on various upper and lower respiratory tract diseases and conditions, and then list the classifications and provide examples. Tell me what they do, how they do it, who can use them, who can't use them, and some of the side effects you need to be aware of for all that stuff. So kind of a busy chapter when you put it in that aspect. Okay, so before we start talking about asthmatic medications, I just want to do a brief overview of what asthma is. Asthma, most simply defined, is a chronic pulmonary disease with both inflammatory and bronchospasm components. So to treat asthma, we will give patients we'll always give them some sort of a bronchodilator to help with the bronchospasm. And then they'll normally be on some sort of an anti-inflammatory agent as well to reduce the inflammation associated with it. And to give you a visual, if this is a little bronchiole in your lung, the one on the left side of the screen is going to be your normal bronchiole. So you can see how there's a nice opening there. Air can flow in and out, and carbon dioxide and oxygen can be exchanged and all as well. Around these bronchioles, there's all these smooth muscles, and these smooth muscles are what control the size of your bronchioles. So then if you come over here to a patient with asthma, you can see how the smooth muscles on here, it's like strangling the bronchiole, which causes bronchoconstriction, so it makes our opening a lot smaller. The other thing you can see here is the membrane on the one on the right side of the screen is quite a bit thicker than the other one, and that's the inflammation component. So our medications are either going to work on relaxing the smooth muscle, which is causing the constriction, or work on being an anti-inflammatory, or doing both. So the first group of medications we're going to talk about are the bronchodilators. With the first type of bronchodilator to be covered, the beta-adrenergic agonist. So now we're talking about a beta agonist. How these work is they agonize the sympathetic nervous system, or they increase the response of the sympathetic nervous system. And these are focused particularly on beta 2. If you think back to, I think it was chapter 18 was where we went over the different types of receptors and what each receptor did. So beta 1 is located kind of on the heart and on the kidneys. Beta 2 then is located on the lungs, the blood vessels, the kidneys, and the liver. So these medications are typically aimed at only working on beta 2, although at a high enough dose they can also stimulate beta 1. But even just focusing in on beta 2, if you think about just where your beta 2 receptors are located, they're kind of all over the body. So we still see some systemic side effects from it going all over the body. But because it's an inhaled medication, there will still be fewer systemic side effects. Just know that they do exist as well. So, as far as those beta 2 receptors on the lungs, what they do when stimulated is they relax the bronchial smooth muscle, and that's the muscle that surrounds the bronchi and bronchioles, and controls their sides. And when those contract, it causes constriction, and the constriction is going to reduce the amount of oxygen-carbon dioxide exchanged. And then when they relax, which is what they do when they're stimulated, it's going to cause dilation. So that opening gets quite a bit bigger and allows more air exchange to go through. Classification of these can be either by route, and by route we have oral, injectable, or inhaled. Most of your patients are going to be on an inhaled beta agonist, whether it's long or short acting. Most of them are going to go via the inhaled route. And the reason why the inhaled route is the preferred route is, one, it acts really, really quickly, and two, it has very few systemic side effects associated with it. Why it acts really quickly is because the lungs, it's got a large surface area to be absorbed on, so it's not just trying to go through one door. You can think of it as going through a whole bunch of doors, so it all gets into the system fast. And then the lungs also have a very rich blood supply, and good blood supply is something you need for your drug to be picked up and to start working. The reason why they don't produce very many side effects when going by the inhaled route is you can think of that as kind of a topical form for your lungs. So you're essentially just putting it on your lungs, allowing it to work on your lungs, but it doesn't go very far from the lungs. It typically will stay there, although there will always be a certain percentage that gets through and starts going systemically. It's a very small percentage, so therefore there's not a lot of systemic side effects. The oral might be used like a tablet. Beta agonist might be used to help reduce the frequency of attacks, or it might be used if somebody has a lot of acute attacks and they're trying to get the asthma under control. They might go on like a 10-day course of a beta agonist. And then the injected are typically only it's always only in the hospital, and it's only for really serious situations. They're not used very frequently at all. As far as the other form of classification beyond the duration of action, and this is where I see it most frequently classified as, and patients will have either a short or a long beta agonist. They do make intermediate beta agonists, but we don't use them very frequently. Normally what patients have is their long-acting beta agonist that they'll take twice a day because it acts 12 hours. So they take it when they get up and they take it when they go to bed, and then they have kind of control around the clock. They'll also have a short-acting beta agonist, and that's going to be what they call their rescue inhaler to help terminate an attack. So those are your two types of classifications. As far as for your indications, it can either be used to prevent an attack or to help terminate an attack. And this is one that can terminate an attack. A lot of your asthmatic medications are aimed at preventing attacks, but your beta agonists are one that can either prevent or terminate an attack. They're kind of like your antihistamines with your allergies. They can either prevent or terminate allergies. Well, these can prevent or terminate an attack. If you're taking it to prevent an attack, you're probably taking a long-acting beta agonist because it takes it a while to kick in, but then it lasts a long time. If somebody's having an acute attack and they can't breathe now, then they're going to want their short-acting beta agonist because it's going to terminate that attack, cause immediate bronchodilation, and immediately allow them to breathe. If your patient's not breathing, not much else matters. So we always want to get them breathing again, and the best way to do that is by giving them a short-acting beta agonist. Contraindications: if they're allergic, they shouldn't take it because it's not going to help. And then I have use cautiously. And the reason why I say use cautiously is if you have a patient, and it doesn't matter if they're hypertensive at a high risk of stroke or whatever it might be, if they have an acute asthma attack, you're going to give them a beta agonist. And you're going to give them the short acting. And the reason being, it doesn't really matter if they're hypertensive if they suffocate from an asthmatic attack. And that's what will happen if they have an asthmatic attack and they don't have an intervention, they will die. And even though we have really well controlled means of controlling asthma, people still do die from asthmatic attacks, and it's typically because they don't have their rescue inhaler on them. So in that aspect, if somebody, even if they're at the highest risk of having a stroke possible, if they start having an asthma attack, they need to take their beta agonist because it's not going to matter. They're going to die right then anyways. Therefore, in our patients who are have uncontrolled hypertension, or if they're at a high risk of having a stroke, we do a lot of work on trying to help prevent attacks. So we do a lot of work fine-tuning their long-acting medication so they have fewer attacks. But if they have an attack, we're still going to use their rescue inhaler because we don't want them to suffocate. Some of the adverse effects, I have this broke down to the two different beta receptors, and although these are focused in on the beta 2, understand that at a high enough dose they can still stimulate the beta 1 receptors. So there are some of those beta 1 side effects, and there's also just a few general ones we'll talk about. They all come from stimulation of the sympathetic nervous system, so kind of have that in mind. In fact, you might even want to grab Chapter 18's notes so you can kind of have that layout next to you as we go through these. And I start with beta 1 just because it's 1 and first in numeric order. So if beta 1 gets stimulated, it's going to cause an increased heart rate from stimulation on the heart. It's also going to increase blood pressure from an increased renin release. So this is something that you don't necessarily see that increase right away, but over time it can cause an increase from the increased renin release, because remember, renin causes vasoconstriction plus it causes fluid retention, so it increases your blood pressure. Now your beta 2 receptors, and what's more likely to happen is going to be vasoconstriction from your blood vessels, which is also going to bring up your blood pressure. Now this will act quickly and then it'll decrease fairly or go back to its normal level fairly quickly as well. The other thing that can happen is hyperglycemia from an increased glucose release from the liver, because when you stimulate the sympathetic nervous system, it causes the liver to let go of some stored glucose so that you have the energy to run or fight or do whatever it is you need to do. And then because beta 2 receptors are also located in the smooth muscle tissues, sometimes it causes just a fine tremor. So sometimes if you have the patients hold their hands in front of them after an albuterol treatment, you'll notice just a really fine tremor. Some of the general adverse effects which come from the increase in norepinephrine, epinephrine include insomnia, restlessness, and a little bit of a headache as well. Some of the interactions, and I don't think I have a slide for this, so we'll just quick talk about the interactions. If somebody's taking both a beta agonist and a beta antagonist or a beta blocker, it should make sense that those two tend to cancel each other out a little bit, because one's increasing and then you take the other one and it decreases. Or you can take one to suppress the reflex and then you take one to increase, so they cancel each other out. So therefore they just diminish each other's effectiveness. The other interaction is the MAOI antidepressants, and if taken at the same time as a beta agonist, it can still stimulate a hypertensive crisis, kind of like the Sudafed or the adrenergic agonist can when we were talking about allergies. Same thing with these medications. Some of the drugs that you need to know. So I have just two listed, although there certainly are more that exist. We're just going to focus in on these two. The first one is albuterol, and albuterol is going to be your short-acting inhaled beta agonist. So this is going to be your fast-acting, it's going to be your rescue inhaler. It has a full onset of action within 5 minutes. So as soon as a patient takes a puff of this, immediately the bronchioles start opening up. And how we want patients to use this is when they feel an attack coming on, or if they start feeling short of breath, they're going to take one puff, and then they're going to wait 60 seconds or a full minute, and then they're going to take a second puff. What this does by giving a little bit of time between the two puffs is it allows the medication, which is hitting kind of the top of the lungs, to open up the top of the lungs. And then after a minute goes by, when they take that second puff, it's going further down into the base of the lungs to dilate down there too. So it's just a little bit more action. versus if they took 2 puffs right away, it's just going to work on the top part of the lungs, and then they'd have to take another puff if they wanted to open up the lower part of the lungs. And typically when they have an attack, it's the entire lung, so we do want to open everything up. Duration of action is only about 4 hours. And if a patient is using their albuterol every 4 hours, they need to go get reevaluated and probably get put on a different maintenance therapy because they really shouldn't be having attacks that frequently. Our goal for asthma treatment is to not have any attacks at all and just have their albuterol on them for freak incidents or freak accidents, because that could always happen, but our goal is for those to be non-existent and for them just to be on their maintenance therapy. So they'll use this either when they have an attack as their rescue inhaler to terminate it, or to help prevent an attack. And sometimes patients, if they have exercise-induced asthma, they'll just take their albuterol before exercising, especially if they have poorly controlled asthma, to help prevent an attack from that trigger. Or the other thing might be if they know they have like allergy-induced asthma, and they know they're going to a house that has a cat in it, they might take their albuterol like right before they walk through the door to help prevent an attack in that manner as well. They do make an oral long-acting albuterol. The oral is going to be long-acting just because it has to be absorbed into the system before it does its duty. So an oral albuterol is not going to terminate an attack, but it might help prevent an attack. Honestly, oral albuterol really isn't used that frequently, so I wouldn't get too hung up knowing about that. Some of the side effects of albuterol, it's going to be a little bit more potent than the long-acting because it tends to just be an overall more potent medication. But your side effects you need to know are the nervousness, tremor, and tachycardia that all come from the stimulation of those beta-2 receptors. Because a small amount of it does cross and get systemically, it's going to cause a few systemic things such as the tachycardia. Might also cause a little bit of a hyperglycemia, but those should be fairly minimal. The other beta agonist you need to know about is salmeterol or Servant. Salmeterol is going to be your long-acting inhaled beta agonist. So this is one that acts 12 hours, and typically patients will either take it once a day if they have mild asthma, or they might take it twice a day to provide around-the-clock coverage as well, so in the morning and at night. And salmeterol's purpose in life is to prevent an attack. So albuterol is going to terminate an attack. Salmeterol is going to prevent that attack from happening. Now there is a black box warning because this happens frequently enough that patients will accidentally take their salmeterol when they're having an attack because they either get the two mixed up and they just grab the wrong one, or they're confused on which one works. If a patient was to take salmeterol instead of albuterol during an asthma attack, they would die because salmeterol is not going to act quickly enough to terminate the attack. And what would happen is their airway would clog off and they would pass out and then they would die of asphyxiation. So that's what the black box warning is all about, is patients mixing the two inhalers up because it's not uncommon for them to have both of them, one for morning and night and then one that they're just supposed to keep on them in case they have a trigger. If they screw that up, bad things happen. The other thing with salmeterol is they frequently will combine this with a corticosteroid, which corticosteroid, I want you to think anti-inflammatory immunosuppression. So that just adds both a bronchodilation and an anti-inflammatory component to the medication. So it's working to control both clinical manifestations of asthma with just one inhaler because it's combining the two medications. That might be used for patients who have severe asthma or patients who have advanced COPD, which is chronic obstructive pulmonary disease. Our next group of bronchodilators are going to be the anticholinergic medications, and these are going to work essentially the opposite of how your beta agonists do. So these are going to suppress the parasympathetic nervous system, which then, I shouldn't say the opposite, but they're like the flip side of the beta agonists. They act similarly, but they take a different road to get there, if that makes sense. And how these work is they block the parasympathetic nervous system, which then allows the sympathetic nervous system to dominate the body. And how they do this is they suppress acetylcholine, which is the neurotransmitter that causes your parasympathetic nervous system to function. So if you stop acetylcholine, you stop the rest and digest, or you inhibit the rest and digest portion of your sympathetic nervous system. By doing this, it stimulates acetylcholine stimulates bronchoconstriction. So if you block acetylcholine, you cause bronchodilation. And then acetylcholine also reduces secretion. So it induces secretion. So when you suppress acetylcholine, it reduces the secretions. I think you need to change my little bold thing up there. I keep looking at it thinking it doesn't look right. When you suppress acetylcholine, you stimulate bronchodilation, as what happens, which would then open up the airways. I've got that all sorts of backwards on your PowerPoint, and I think I have it all sorts of backwards on your outline. What I was trying to say is when acetylcholine binds to the receptors on the lungs, it stimulates bronchoconstriction. So then when you suppress acetylcholine, it stimulates bronchodilation, which would open up the airways. And suppressing acetylcholine also reduces secretion, so then they have less mucus in their lungs. Another way to think about that is it's just suppressing the parasympathetic nervous system, which will then allow the sympathetic nervous system to kick in. One of the drawbacks to the anticholinergics is that it has a slower onset of action than the beta agonists. For this reason, they don't get the title of being a rescue inhaler because they don't act quick enough to rescue anybody, but they are really good at preventing bronchospasms in patients who have asthma and COPD. So typically this is another one of those preventative type medications. Some of the contraindications, if they're allergic to the medication, or if they have certain food allergies, because some of these food particles are actually used in the production of anticholinergic medications. So patients who have soy allergies or peanut allergies will use anticholinergic medications with caution. Some may still be able to use it, but for the most part we say use cautiously, or if you can get away with using something else, just don't use it at all. The other thing, if a patient is allergic to atropine, which is another anticholinergic medication, there's typically a cross allergy with your asthmatic anticholinergic medications in atropine as well. So if they say they're allergic to any of those, then we use anticholinergics with caution. Some of the side effects of your anticholinergic medications, again, you're suppressing your rest and digest, so you essentially dry the body out a little bit. So a dry mouth and sometimes a dry throat or a sore throat, less likely, but potentially could cause a heart palpitation or tachycardia. And then your book goes into detail about a couple systemic side effects as well. What I want you to take away from this lecture is if patients are using their inhaled medications appropriately, the systemic side effects shouldn't happen. There's a small chance that they could, but such a little amount of medication is absorbed systemically when used appropriately that it's unlikely to happen. But some of your systemic side effects would be like the nausea and vomiting, constipation, urinary retention, those types of clinical manifestations. But again, if they're using these appropriately and they're not overusing them, they're not swallowing them, those are very, very rare. So as far as like when you're trying to memorize stuff, I wouldn't get too hung up on that because it's a very rare occurrence that that's going to happen. Well, there's two drugs you'll need to know from the anticholinergic component here. The first one is pratapam or Atrovent. This drug is very old. It's the first anticholinergic on the market for asthma. And it's very similar in chemical makeup to atropine, which is why there's a cross allergy between atropine and your anticholinergic asthmatic medications. The routes here does come in an oral form, but it's very rarely used, and then it comes in an inhaled form, which is more likely to be used. It's typically a twice-a-day dosing regimen, and it's going to be used for the prevention of an attack. So if they're on Atrovent, they'll take it at 7 a.m. and 7 p.m. so that they have around-the-clock coverage, or 8 a.m., 8 p.m., 9 a.m., 9 p.m. You get the gist. 12 hours apart, morning and night typically, and produces that around-the-clock control. It's typically used for patients with severe asthma. It'll typically be used in combination with an anti-inflammatory medication, or if they have really, really severe asthma, it might also be used in combination with a beta agonist. The other time when somebody might be on Atrovent instead of a beta agonist would be if they don't tolerate it. So if they try salmeterol and they don't tolerate it, side effects are such, or they're allergic to it, or whatever it might be, then they'll probably try an Atrovent because it would be our next best therapy after the beta agonists. The other drug you need to know from the anticholinergic world is going to be Spiriva, and Spiriva is very similar to Atrovent except for it's newer. It's the newer alternative to Atrovent, and this guy's claim to fame is it's got a 24-hour duration of action, so it's a once daily medication, which is a little bit more convenient for patients. Just every morning when you get up, you take your Spiriva and you're good to go for 24 hours. Because it has a long onset of action, it's going to be used for the prevention of attacks. It's not going to terminate anything. It's only going to prevent an attack. And for patients who have severe asthma, they may use it in combination with either a beta agonist or with an anti-inflammatory agent as well. The next group of medications we have to talk about in the last bronchodilator, I believe, before we start talking about anti-inflammatory agents, are the xanthine derivatives. And these are also known as a methxanilline derivative as well. And the reason why I throw that term on is I have a mnemonic at the end of this PowerPoint that I need that methxanilline name on there to make it work. So that's why I've got that in there. But they're a xanthine derivative. And how these work is they're actually chemically related to caffeine. So if you think of caffeine as being a stimulant, these guys act in a very similar nature in the fact that they're a stimulant. How they cause their stimulation is they increase the substance called CAMP, C-A-M-P. And what CAMP does is it induces smooth muscle relaxation, which then allows bronchodilation to occur. They also stimulate the central nervous system, which is going to help act a little bit on the respiratory center within the brain. The other thing that by stimulating the sympathetic nervous system, not that this helps your asthmatic patients, but it'll help explain some of the side effects, is it increases the cardiac contractility, known as a positive inotropic effect, and then it also increases the heart rate. Because it's stimulating the heart in such this manner, it typically isn't used in patients who have cardiac disorders because it's really hard on the cardiac system as well. Some of the indications, and the other thing with these, keep in mind that this group, the xanthine derivatives, are more effective in neonatal people, little NICU babies, than they are on adults. So that's the only time I've ever seen this used was when I did an internship in the NICU. They'll sometimes use a xanthine derivative on a NICU baby to help stimulate the drive to breathe and to help, it doesn't develop the lungs, but it just helps the patient breathe if they're in respiratory depression or respiratory distress, I should say. Anyway, they could be used in adults for asthma or COPD to help prevent an attack, but they would be like the third line behind the beta agonists, behind the anticholinergics. If those medications didn't work, then they might consider this. So it's really a third line medication. They tend to, like I said, work better in the infants. Is typically where we see these used for little babies who are in respiratory distress. Some of the contraindications for this drug include if they're allergic to it, if they have cardiac dysrhythmias, because there is that positive inotropic effect and it does increase the heart rate. If they already have a dysrhythmia, this is a bad medication to go on. The other thing with this is it lowers the seizure threshold because it's stimulating the sympathetic nervous system or the central nervous system. So therefore, patients who have seizure disorders will be more prone to having a seizure while they're on this medication. So we try to avoid it in that population as well. Some of the side effects, there's a few mild ones, some GI things, nothing too terribly concerning there. But what does become concerning with this medication, it doesn't matter which one you talk about within this group because there are a couple different ones, even though we're only covering one. Anyone that belongs to this group is going to have a very narrow therapeutic range, which means they have the potential to become toxic really, really fast. What happens when the medication surpasses its therapeutic range, so it gets too high, it causes tachycardia and dysrhythmias, and it can cause a cardiovascular collapse. So it's not the safest medication in the world. If somebody overdoses on this, how we treat it is with activated charcoal. They get some activated charcoal and it helps reverse. It helps zap up any medication that hasn't done any damage, so it kind of stops the damage, and then there's lots of supportive mechanisms as well. But that's another reason. One, these aren't very potent. They're not very good for adults. and two, they're very touchy medications. So that's another reason why they're like third line. If absolutely nothing else works, we could use this. The other reason why we don't like using xanthine derivatives is they interact with essentially everything. Many of the medications they interact with we haven't covered yet because there's a lot of like antibiotics, antivirals, immunosuppressant type stuff that we haven't covered, so we're not going to worry about it yet, but just kind of make a note that they also interact with everything. They don't share the sandbox with any other medication. So they're not a very friendly medication to use, but they do exist, so we'll talk about them. The only drug you need to know from here is Theodor. Theodor is kind of fun, the fact that it comes in oral, rectal, or injectable routes, but what you don't see it come in is inhaled. And remember, when you're trying to cure respiratory distress, so an asthmatic attack, an inhaled form would really be your preferred form. So here's one more reason why this might not be our favorite drug to use for an asthma attack is the fact that we can't give it in an inhaler. It's got to be either orally or rectally or injected into a patient. And if you're giving this via injectable route, understand that's going to be a high risk of pushing that patient into a toxic level, which you don't want to do either. All the medications which belong to this group have got a narrow therapeutic index. The index for this, or the range for this specific medication, is 5 to 15 micrograms per milliliter. Because it's such a narrow range and such a low range, there's lots of frequent monitoring that goes along with this medication. Also, because it's so touchy, it's really not ideal for long-term therapy, but it could be used again when nothing else works, so it's really behind the beta-agonists and the anticholinergics. They could try using this medication, or they could try using this medication in addition to another drug. But for the most part, those of you who decide to go into the NICU, you're going to be the one who work with this medication the most. Okay, so that's all of our beta agonists. Now we're stepping onto the other side of asthma, which is going to be the inflammatory side of it. Our anti-inflammatory agents, we're going to talk about a couple of them. And the first one we're talking about are the leukotriene receptor antagonists. So your leukotrienes are part of your immune system, and when you hear immune, think inflammation. So how these antagonists work is they block the inflammatory process within the body. Leukotrienes are the mediators of the immune response, which are involved in allergic reactions and asthma. Because we're working on the immune system, this group of medications tends to be most useful for patients whose asthma is induced by some sort of allergen. So by cats, by dander, by ragweed, something that they're actually allergic to. It's not going to be as helpful in patients who have like exercise-induced asthma because that's not being caused by an allergen, it's being caused by a distress on the body. So if you can kind of think about it in that aspect, these tend to be better for patients who have allergic asthma. What happens when leukotrienes are released is it promotes edema, inflammation, and bronchoconstriction. So by blocking it, you're going to reduce edema, reduce inflammation, and then cause bronchodilation as well. Or you're going to stop the edema and inflammation and stop bronchoconstriction. Indications for this, it's not a rescue inhaler, so it's going to be used for the long-term treatment of asthma, and it's going to be used to prevent an attack from occurring. So this will be a daily medication that they take all the time, like every day, to help prevent an attack. The other time you might see this used is sometimes patients will use it for allergies as well, because again, it's working on the immune system to help stop that inflammatory process. Your adverse effects are really going to be quite minimal for this. Might cause a little bit of a headache and a little bit of nausea, but for the most part, patients say these medications are pretty easy to tolerate and they don't mind being on them too much. The only drug you need to know from here is Singulair. Montelukast is the other name for it, but Singulair. And this you'll see commercials both for asthma and for allergies if you watch a lot of TV. How it works is it disables a portion of the inflammatory process by altering the immune system a little bit. And the big selling point to this is it's safe in children as young as 2 years of age. So this is one that's good for children. Also, it's pretty good for patients who are pregnant because it is a pregnancy category B. So we know it's fairly safe there. It only comes in the oral route, so it's going to be a long-acting. It's not going to be good at terminating an attack. But again, when taken on a daily basis, it's good at preventing attacks. The next group of medications we're going to talk about are the corticosteroids again. These now we're going to work about the inhaled, not the intranasal form, but the actual inhaled form of corticosteroids. And they're working similar to how the intranasal ones worked, except for now we're talking about them working in the lungs versus working in the nose. So what they're doing is they're inhibiting inflammation and they're preventing the accumulation of various inflammatory mediators, including the leukocytes, mast cells, and macrophages. By doing this, it's going to decrease vascular permeability, which is going to result in decreased inflammation and decreased edema. So it's just working on the inflammatory component of asthma. For that reason, it's almost always going to be combined with a bronchodilator for maintenance therapy as well. The other trick that these do, or the other benefit to these, is that they increase the body's sensitivity to beta agonists. So because you're going to be using a beta agonist anyway to help with the bronchodilation component of it, it's kind of nice that these drugs make the patient's body a lot more sensitive, or they have a more pronounced effect of those beta agonists. So the beta agonists work better when you're on a corticosteroid as well. For this reason, it helps improve asthma control. But with corticosteroids, just like with your intranasal, how you had to take it like 3 weeks before allergy season started, same thing here, is it takes a long time for these drugs to kick in, and we'll go over the nitty-gritty of it in a little while, but they're kind of a slow-acting medication. The routes of administration here, they can come oral, IV, or inhaled. If somebody's taking an oral corticosteroid for asthma, it's just going to be a short course of therapy. They're not going to be on a daily prednisone for asthma. Typically, they'll be on like a 7 to 10 day course, and it's just going to help stop the acute flare-ups of asthma. So somebody who might be on the oral prednisone for asthma might be somebody who they've been having attacks daily. Even though they're on their maintenance therapy, they're still having attacks. They will put them on an oral corticosteroid while they're also messing with some of their maintenance therapies to help stop those frequent attacks from happening. Because again, our goal for asthmatic patients are to help prevent attacks from occurring. Now, because this is a tablet that they're taking, it's not going to terminate an attack. It's not going to act quick enough to terminate an attack. The patient won't have time, but it'll help reduce the severity and the frequency of attacks. Also, because it's a tablet that's getting absorbed systemically and going all over in the body via the bloodstream, they are going to have all the systemic side effects associated with corticosteroids, which there's many. Typically, there's 2 types of oral corticosteroids they can use. They can either use prednisone or methylprednisone. Both are pretty commonly used. Now, the IV route is not going to be a real typical thing you see, so we're just going to kind of step over the IV route for now and go to the inhaled route. This is where you're going to do a lot of education, probably a lot of monitoring on, because most of the time when a patient's on a corticosteroid for asthma, they're going to go home with an inhaled form of it. It is the best route for controlling asthma, as I've alluded to before. Medication which is applied directly to the lungs, it hits a large amount of surface area on the lungs, so it's got lots of receptors it can stimulate or block or do its magic on. Also, there's a large blood supply to the lungs. Those 2 things, a large surface area and a large blood supply, really promote a fast action for these medications. Also, because it's just going to the lungs and just a little bit of it's getting systemically absorbed, there's going to be very few systemic side effects. Kind of think of it as just an ointment for the lungs and it doesn't go anywhere else, which makes these really desirable for long-term use because you don't have all the long-term side effects of corticosteroids when taken in the inhaled form. And again, they're kind of slow-acting, so they're best for preventing an attack rather than terminating an attack. So the indications, again, they're going to prevent an attack. They're not going to terminate, they're just going to prevent an attack. And they may also be used to help control COPD symptoms as well. Some of the contraindications include a drug allergy. If they're allergic, we don't give it to them. And then we'll use these cautiously in patients who are immunosuppressed. It's not that they can't use them, we just need to be a little bit careful with these. One of the side effects of corticosteroids is immunosuppression. So if they're already immunosuppressed, they're at a little bit higher risk of developing an infection. The other thing, and I think I say it here and I say it again a little bit later because I want you to remember it, is with corticosteroids, when they take them in their inhaled form, they come in their little inhaler that they take a puff of, and then you can take that inhaler apart and clean it. If a patient's using a corticosteroid through that inhaler needs to be cleaned after every use, because what happens if you don't clean it is it allows thrush or fungus to grow in it, and then if they start taking their corticosteroid and there's little fungal spores already in their container and they deliver that to the lungs, it doesn't take much for an infection to start. I was reading a case study actually it's been a little while ago, it was about a year ago, about a lady that she presented to the doctor's office and she had terrible rectal itching, like terrible. She had horrible, and they showed a picture of it because they were that cool, but like her bottom was all red, it was thrushy, it was yeasty, it was just disgusting. And the case study went on to explain what she was on and all her comorbidities, but they traced it back to it was actually her inhaled corticosteroid she was taking to prevent asthma, that she wasn't cleaning the canister for it. So when she took it, some got to her lungs, but then she was swallowing some of that medication, and I don't know how they diagnosed it, but they did a scope, I think they did a scope actually is how they did it, and she had thrush growing from just behind her throat all the way down to her rectum because of her corticosteroid. So it's really, really, and she wasn't immunosuppressed. She was your quote-unquote healthy patient. So it's just really, really important for anybody who does have a risk of infection that they're getting their canisters cleaned, because otherwise it doesn't take much for an infection to go widespread. And you can imagine how if you've ever had thrush or know somebody that's had thrush, it's very itchy. Or if you've ever had like a yeast infection, it's very itchy. So if you think of that itch internally and all the way through, it would be terrible. So that's one of the big negatives of corticosteroids, is it can cause that fungus to grow, which isn't much fun. Also, if a patient has an active systemic fungal infection, we use these with caution, and it goes back to the immunosuppression side effect of these. So, moving on to the adverse effects. Again, with the inhaled, there's going to be less. It's a small chance of any systemic thing happening unless the patient starts to swallow it, such as the lady in the case study that we talked about on the previous slide. If they're not swallowing their medication though, or overdosing on it, they should be okay. Some of the inhaled side effects will include pharyngeal irritation, so kind of a sore throat, coughing, dry mouth, and then that oral fungal infection, which is why it's so important to take the canister apart and clean that whole thing out after each and every use. And then with the oral corticosteroids, there's going to be more side effects. So if they're on a short-term course of like prednisone to help suppress suppress the frequency of attacks, then they're going to be fair game for all the side effects we covered in chapter 33. And I include just a few of them in your outline. You could certainly go back and add probably twice as many as I added there, but some of your short-term ones particularly would be fluid and electrolyte imbalances. They'll start retaining fluid. Notice that their shoes and their rings probably don't fit quite right. They might have some mood swings, anxiety. They'll develop acne really bad. And then some of the long-term, which they shouldn't be on prednisone long enough to cause it, but some of the long-term ones would include osteoporosis, weight gain because fat gets redistributed. Again, look at chapter 33 if you don't remember these side effects, because that'll be a big component of this exam, but then also your final exam. That's something that you'll want to know. Some of the interactions with corticosteroids, with inhaled, there's really very few. But with oral, there's a ton. And I just listed again a few. If a patient's also on immunosuppressant medication, it's going to increase the risk of toxicity from that immunosuppressant. It increases the toxicity associated with phenytonin or Dilantin, the anti-seizure medication we learned about. It interferes with the action of certain antibiotics, which you don't have to worry about which antibiotics, because we'll cover that next week. And then with your diuretics, furosemide and hydrochlorothiazide. And I don't know what I was thinking. Add the thiazide onto your hydrochloride on your sheet. That should be hydrochlorothiazide. It can induce hypokalemia because they both cause the depletion of potassium. So there's quite a few when we come to the oral corticosteroids, but the inhaled are relatively there's relatively few. So a few of the nitty-gritty. The first drug we're going to talk about is fluconazole, and this is a twice-daily inhaled medication, and it's meant to prevent the occurrence of attacks. So they'll take it once in the morning and once at night. And again, it's really, really important that they clean their equipment after each use. That is going to be a key thing for you to remember. If it's not clean, it allows that buildup of thrush and then can cause that fungal infection. And we've already talked a little bit about that. So if you didn't already, make sure you star that. Typically, it's combined with some sort of a bronchodilator for best relief. And what they'll a lot of times do is put both a long-acting beta agonist and fluconazole into one inhaler. So they just have to take the one puff, but they're getting both medications. And then that provides a long-term relief of their asthma attacks. Now, like I said, these are really, really slow-acting medications, so you see improvement of asthma symptoms in about 2 weeks, but then it can require up to 4 to 8 weeks for maximum benefit. So this certainly isn't a quick fix. Kind of like with allergies, you have to take it 3 weeks before the allergies are introduced to your nose for them to work. Same thing here, you don't have to take it before you develop asthma, but you're going to take it for a while before you really notice a difference. So make sure you're telling your patients that so they don't get discouraged and quit this therapy, because if they quit after 1 week, we have to start all over from square one. So just make sure you tell them it's going to take some time. Keep your albuterol near you in case you have an attack in the meantime, but eventually you'll feel better, which I'm sure isn't going to make them feel better in the here and now, but eventually it will get better. The next drug for you to know is the methylprednisone or just prednisone, and this would be if they happen to be on some sort of an IV or an oral tablet route. This would be the drug they would use. And again, it's just used for short acute flare-ups. It's a short course therapy, and because it's going systemically, there's going to be a higher incidence of side effects noted. Now we have just a few this and that. The next one is going to be the monoclonal antibody anti-asthmatic, is how your book calls it. What this is it's a type of medication. It's actually a biologic therapy, which is kind of the new thing in pharmacology. And it's a very specific medication. It's really exciting. For some people, it works really, really well, but if you don't happen to function in the way this medication does, it doesn't work at all. But it's a biologic therapy. It's mutating or manipulating your body's own immune system. And what it does is it manipulates the monoclonal antibodies to attach to a specific receptor in a target cell. And by doing that, it decreases the inflammation response. The only name you need to know here is Xolair. We'll probably hear more about it in the future, but it was just released a couple years ago. It's not widely used yet, but I think you'll see it on the up and coming. And then the other brand new guy is Daliresp, and this is actually a medication. The medications we've talked about up until this point in chapter 37 could be used for either COPD or asthma. Daliresp is actually a medication which is specific for COPD, and what it does is it acts in kind of a roundabout way by inhibiting an enzyme which causes inflammation. By inhibiting that enzyme, it decreases the inflammation, and it's going to reduce the exacerbations of COPD. But again, it's not for acute attacks, it's going to prevent attacks. I got some of the side effects listed there: nausea, diarrhea, headache, insomnia, weight loss. Again, nothing that you need to know too much about that medication because we're not seeing it used very frequently in practice. But I think you'll probably hear more of it later on in your practice as you get out and become nurses and physician assistants and respiratory therapists and what have you. It's kind of on the horizon. So, for remembering all that, I found this little mnemonic, and it's the SLAM BAM. Although we're missing the A in the SLAM, just ignore that. That kind of tripped me up for a while. But this is a quick way that might help you remember these asthmatic medications. And the SLAM is going to be your anti-inflammatory, and the BAM is going to be the bronchodilation. So for your SLAM, you have the S, and the S stands for your SON medications, which are your corticosteroids, your fluconazole, methylprednisone, prednisone. Those that have this SONE in the generic name. So that's what the S stands for. The L is going to be the leukotriene antagonists, and that would be like your singular medications. And then the M is going to be that monoclonal antibody, the Xolair, that we just talked about. These medications are all anti-inflammatory, so they're stopping the inflammatory component. On the flip side of the screen, you have your BAM, and these are going to be the bronchodilating medications. So these are actually going to open the lungs up a little bit more. And for these, the B stands for the beta agonist, and it incorporates both the short and long-acting ones, but the beta agonist. And then the A is going to be the anticholinergic, and the M, this is why I had to have the methanoline derivatives, not just the xanoline derivatives, so the M matches up with my M here. The other thing I want to bring to light is if you have a patient that's getting, say, both albuterol and fluconazole, so they're getting both a bronchodilator and they're getting their corticosteroid. Between the two, especially if they're getting that short-acting bronchodilator for any reason, and sometimes we see this with COPD patients, it's important to give the bronchodilator before the anti-inflammatory medication. And the reason being is they'll have inflammation the entire course of their lungs, so by giving the bronchodilator, it kind of opens up the entire lung way so that anti-inflammatory medication can travel to the base of the lung as well. So if you happen to have both, you would give the bronchodilator ahead of the anti-inflammatory to kind of open up the lungs as well. And then for those of you who like lists, because I know there's a few in the class, I just have a quick list here from chapter 36 and chapter 37 for you guys to write down if you wish. They all come straight from your notes. You could certainly create this list as well if you wanted to. But I'll let you pause the presentation if you want, and that is all the more I have to give to you guys right now.